Low back pain is one of the commonest problems we face in our day-to-day OPD practice. So today's talk is about how to approach a patient with low back pain in a non-specialist setting, that is as a primary health care. So a thorough examination is a must to rule out any major disease. So what are the objectives of today's talk? So how will you diagnose a patient with the low back pain, which includes history, examination and investigation. A brief comment on mechanical, inflammatory, root nerve compression and malignancy, and what are the common causes of the pain, and the role of the primary health care in management, and when will you refer to a specialist using the red flag signs. How will you educate the patient about the prevention of the recurrence of the low back pain. So the lifetime prevalence of non-specific low back pain is estimated 70 to 80%. Almost all would have had the back pain at least once in their lifetime. Next to the common cold is the main reason for the missed workout days and the physician visit. And the cost of the low back pain is more than $50 billion worldwide. So there is a saying, eyes don't see what the mind doesn't know. So before we see a patient, we should know at least the basic anatomy and the differential diagnosis so that we can look for the problems. So the vertebral column consists of 33 vertebrae. You have 7 cervical, 12 thoracic, 5 lumbar, 5 sacral and caudal, 4 caudal. The sacral and caudal fuse together to form a sacrum. So you'll have a normal thoracic spine kyphosis, and there will be lordosis of the lumbar spine. So today we'll be concentrating on the lumbar spine. So this is the vertebra. This is side view, and this is view from the top. This is the vertebral body. This is the superior articular process, which articulates with the inferior articular process of the above vertebra. And this is the inferior articular process. And in between these two, you have the pars interarticularis. This is the pars interarticularis. And this is the spinal column through which the spinal cord passes. So in front, you have the vertebral body. On the sides, you have the pedicle, both sides. And this is the lamina, and this is the spinal process. The basic anatomy is needed to rule out in which part it gets affected. This is the functional spine unit. So the two vertebrae articulate together. This is the inferior articular process of the above vertebra. The superior articular process of the below vertebra form the fascial joint. And the nerve root passes through the intervertebral foramen, that is in between the two vertebrae. And this is the side view. You have the intervertebral disc in between the vertebrae. So let us see the cross section of the disc. So the disc has centrally nucleus pulposus surrounded by annulus fibrosus. Normally there will be a concavity on the posterior aspect of the disc, which can be seen well in an MRI. So all these vertebrae are held together by various ligaments and muscles. The most important ligaments are the anterior longitudinal ligament, and this is the posterior longitudinal ligament, and the ligament of flavum, which connects the laminae. And there are various muscles which hold the column together. So once you know the anatomy, you should know what is the differential diagnosis of a patient with low back pain. It can be divided into mechanical cause, systemic cause and referred pain. The most common is the mechanical cause. So the mechanical, you can have a lumbosacral strain or sprain, herniated disc, the degeneration of the spine, compression fracture, spondylolysis and spondylolisthesis. See, these are the most common causes. And the systemic, you have the malignancy, the multiple myeloma, and the secondaries, an infection, osteomyelitis, and the most common is the tuberculosis of the spine. The inflammatory cause is ankylosing spondylitis or a reactive arthropathy. So the referred pain can be due to acute aneurysm, pelvic disease, prostatitis, renal problem, stones or pyelonephritis, gastrointestinal disease, pancreatitis and cholecystitis. Any abnormality in the abdomen can cause a back pain. So once you know the basic things, Come to the examination of the patient. First, you have to ask the history. A doctor who cannot take a good history and a patient who cannot give one are in danger of giving and receiving the bad treatment. And this is 100% true. So you ask for the personal data, the age. The younger the age group, you think of more of mechanical cause. If the patient is more than 50 years old, you should have this secondaries and the osteoporotic compression fracture in mind. The occupation also will give a clue whether his job is of lifting weight or sitting for a long time as an IT people or a driver. So regarding the complaints, you have to ask the onset of the pain and how it started, whether it is acute or chronic, and what was he doing before the pain began, and any history of injury, and also the character of the pain, whether it is sharp, dull, throbbing, or burning pain, and the location, whether it is localized or radiating to the lower limb. And the duration of the pain, if it is less than 6 weeks is acute, 6 to 12 weeks is subacute, more than 12 weeks is chronic. So you have to ask for the intensity of the pain and how it affects his daily routine activities and whether it is interfering with the sleep or walking or driving. The associated symptoms like stiffness, urinary and abdominal symptoms have to be inquired. So next, ask for the paresthesia. Over L1 over the groin, L2 will be affected when there is paresthesia over the anterior aspect of the thigh, L3 in the anterior aspect of the knee, L4 on the medial border of the calf, L5 over the dorsum of the foot, and S1 over the lateral border of the foot and the little toe. Now ask for the history of any morning stiffness, which is common in ankylosing spondylitis, and also any past treatment received for this particular problem. The systemic review, history of fever, appetite or weight loss for malignancy. There is abdominal pain or history of cough or sputum, and ask about the bowel habits, and there is any dysuria and hematuria suggestive of any UTI, and also the menstrual history. And the past history should include any history of trauma and history of any kidney problems, previous back pain or any treatment, and malignancy anywhere else, so to rule out any secondaries in the spine, and also whether had any disc prolapse and any surgery has been done, and obstetric history. The medications, the corticosteroids to rule out osteoporosis and immunosuppressants. This all decrease the immunity of the patient. Please also note history of smoking and alcohol, and you have to inquire the concern, how concerned is the pain, and what is the expectation of the patient, and how does it affect him emotionally and functionally. So accordingly, we have to give the advice. So once you ask for the history, thorough examination is a must. A casual examination is worse than no examination at all because it may give the false hope that the lesion is minor. So physical examination include the general appearance, the noting vital signs, examination of the back, and the systemic examination. So the general appearance, you should see whether the patient is comfortable or not. Sometimes they will be lying, sitting or standing or leaning on something. It will give a clue how intensity is the pain. And also the record the vital signs, and especially the high temperature and tachycardia shows there may be some infection. So the proper examination include the look, feel, move, and test. So what do you look? So look, you have to see the patient from the side and from the back. Look for any deformity. The normal thoracic kyphosis and lumbar lordosis will be obliterated in ankylosing spondylitis. See whether there is any evidence of kyphosis when you see from the side, and scoliosis, whether it is C-shaped or S-shaped when you look at from the back. Also look for the soft tissue abnormalities like a hairy patch or lipoma that may give a clue for spina bifida, and look for any muscle wasting which may be due to disuse. Now also see the shoulder and the pelvic level. There will be one side of the shoulder may droop down because of the severe muscle spasm. Next is the palpation, that is a feel. So the spinous process of each vertebra at the center has to be examined. If there is any tenderness, it shows that it's a fracture, dislocation, or infection, or arthritis. So when you palpate from the top, you can feel a step off in spondylolisthesis. So look for any muscle spasm. The muscle will be tight. It's suggestive of any degenerative or inflammatory process. Also, the tenderness over the sacroiliac joint has to be elicited, which indicates sacroiliitis or ankylosing spondylitis. The next comes the movements. So you have to check all the movement, the flexion, extension, lateral flexion, and the rotation. All the movements will be affected in ankylosing spondylitis because of the rigid spine, and usually the flexion will be affected in mechanical type of pain. So next comes the easier one, the test. The most commonly done test is the straight leg raising test. Ask the patient to lie supine, lift one leg. Normally, if the patient doesn't have pain up to 70 degrees, that means the test is negative and there is no root compression. Suppose if the patient has pain over at 30-degree level, stop at the level, then again dorsiflex the foot. We have to do the dorsiflexion of the foot. That will aggravate the pain and will be 100% sure that there will be no root compression. This another test is that you flex the hip and knee. So to give pressure of using the both thumbs over the knee and extend the knee, and this will cause a radiating pain. This is also a positive test. So this test is for nerve root compression. And also if it's a high level compression, the femoral stretch test will be useful. Ask the patient to lie prone. You flex the knee. If the patient develops pain, that's suggestive of L3 and L4 no root involvement. And if the patient doesn't have pain, you lift the leg and extend the hip. Even in that position, the pain may come. So this is also suggestive of the nerve root compression, L3 and L4. So next component is the neurological testing. So do neurological examination if the patient has any signs or symptoms of nerve root compression. Even then, it's better to do the neurological examination. As I told you, the sensory examination, that is the previously you told about paresthesia. Now you look for any dimness sensation over these areas. These are the L1, L2, L3, L4, L5, and S1 area environment. It's very easy to remember. You come from the top, the groin, thigh, knee, the leg, dorsum of the foot, on the medial side, and the lateral border of the foot. That is a S1 dermatome. Next comes the motor examination. It's just to refresh the basics. So for the grade 0, there will be no movement. If there is any flicker, it's grade 1. Only if there is movement, the gravity is eliminated, it is grade 2. Movement against gravity is grade 3. Movement against resistance, but if it is weak, it's grade 4. And the normal strength is grade 5. And these are all the motor involvement. Here also you can remember from top to bottom. L1, L2 is hip flexion. The knee extension is affected is L3, L4. Dorsiflexion of the ankle, it's L4. The grade 2 extension is L5. And the plantar flexion is S1, S2. Next comes the reflex. Knee jerk will be diminished in L3 and L4 lesion. Ankle jerk in S1, S2 lesion. Babinski reflex and Kloner shows that it's not a lower motor neuron type of lesion, it's only UMN. So at the primary health level, laboratory tests may not be needed, but if you suspect any malignancy or infection, then you have to do the laboratory tests. You do a fasting blood sugar, ESR, C-reactive protein, and blood cultures to rule out infection, and urine analysis and culture, because the renal parenchyma infection can cause low back pain. Imaging. Imaging is done in high-risk patients. Most of the patients with low back pain do not routinely require imaging. So for the first 6 weeks, you reassure the patient and tell them that the symptoms will respond to conservative treatment. If the symptoms persist longer than 6 to 8 weeks, plain X-ray should be obtained at that time. There is no need for MRI for all cases. So this is how you have a look at the X-ray AP view. So you take this segment. This is the vertebral body, and this is the intervertebral disc space in between the two vertebrae. And you have the two oval structures on both sides. That is called pedicle, and centrally you have the spinous process. And this is the sacroiliac joint. So look for any lateral curvature of the spine. This is a scoliosis. It can be due to degenerative or a muscle spasm. And this is the pedicle. This is the oval shaped one is the pedicle. This is the normal pedicle. Here you can see the destruction of the pedicle shows early signs of malignancy. And this is the intravertebral disc space. So this is the fracture transverse process. So if you have any history of injury and there is a lateral tenderness, then you suspect fracture of the transverse process. This is the lateral view. Here you have many clues. This is the vertebral body. This is the intervertebral disc space. This is the pedicle. And this is the articular area. There is a fascial joint. And in between the fascial joint, you have the pars interarticularis. This is the pars interarticularis area. So what you look for in a lateral view? So you look for the anterior and the posterior alignment, whether it is all right. And height of the body. If the height of the body is decreased, it's a compression fracture. I look for the disc space. This is a normal disc space, and there will be narrowing of the disc space in degenerative condition. It's a chronic disc prolapse. And this is the spondylolisthesis. The entire, you can see the posterior alignment is altered. The entire spine has come forward, the L4 over L5. Here you can see a defect in the pars interarticularis. So if there is a displacement, it is called spondylolisthesis. If there is only spondylosis is seen, it's called spondylolysis. It can be seen very well in oblique view. This is the Scottish dog, the ears, this is the mouth part, this is the neck, these are the legs. This is a classical oblique view. You can see the defect here in the neck. This is the normal neck. If there is a defect here, it is called spondylolysis. That is without any displacement of the spine. Sometimes you can see in the lateral view itself, you can see the pars interarticularis defect. And this is a normal one. So next comes imaging. This MRI or CT. MRI is the preferable one. If it is not able to be done, you can do a CT myelogram. So this has to be done with the discussion with the spinal surgeon. And in trauma situations, standard AP view and of the pelvis and the cervical spine has to be done. Usually MRI is not indicated emergency. So you have to consider MRI only if the result is likely to change the management. Suppose you want to continue the conservative treatment even after taking the MRI, there is no point in taking an MRI. So only if you suspect that the patient may need another mode of treatment, you ask for the MRI unless the patient insists for it. So you have done all the history examination and tests, and by this time you should have come to a conclusion whether it is inflammatory and mechanical, and if it is mechanical, and what may be the possible cause. Usually the inflammatory happens in less than 40 years. Mechanical can happen at any age. The progression is the disease is slow in inflammatory and acute in mechanical. Duration of the symptoms will be more in inflammatory when you compare to the mechanical, and also morning stiffness will be more in inflammatory, and the night pain is common. It will be absent in mechanical. Only on the activity the pain will increase, and so the exercises will improve in inflammatory condition, and it worsens in mechanical, the initial stages. And sacroiliac joint tenderness is common in inflammatory, is absent in mechanical. And also the vertebral mobility, that is all the movements of the spine, will be decreased in inflammatory condition, and usually, as I told, there will be decreased flexion of the mechanical cause, and chest expansion will be decreased because all the spines get fused in ankylosing spondylitis, and it is normal in mechanical. So next is the root nerve compression. You suspect when there is a radicular pain and the patient or the pain also increases on coughing. So the malignancy, the metastatic cause is more than the primary tumors of the spine, and it usually seen in patients older than 50 years, and thoracic spine is more involved than the lumbar spine. So if there is any history of fever, weight loss, loss of appetite and neurovascular deficit, you have to think of malignancy, and do not forget to ask for this history, because many times we miss the diagnosis. So those in pediatrics, it was all due to overloaded school backpacks or the psychological causes to avoid going to school. Women ask about pregnancy, and it may be due to psychiatric care. So as I told, about 97% of the low back pain is due to mechanical cause. So again, we'll come back to the same slide. So these are the differential diagnosis of low back pain. So you have to pinpoint what is the diagnosis by this time. So next we'll see the three most important and frequent cases we see. The number one is the lumbar muscular strain or sprain. There will be stiffness and there will be localized tenderness. Usually there will be no radicular pain. So what's the difference between strain and sprain? Strain is damage to the muscle. Sprain is due to ligament injury. So how I remember is strain, you have T there, it's a tendon, so there's a damage to the muscle. The sprain is ligament injury. But clinically, it's very difficult to differentiate between these two, because the treatment will be the same. So it can arise from any combination of pathology involving the disc or vertebrae or the fascial joint or ligaments and muscles. It will be the sharp, intense pain for 1 or 2 days, but usually they recover within 3 months. The risk factors is lifting a heavy object or fall from a height, or poor posture over time, or sitting for a long time, and sports injuries. So if there is any history of this, it's more likely to be the strain. So investigations is not needed when the duration is less than 4 weeks. It is more than 6 weeks. At the primary health level, just an X-ray is enough. So as I told you, you can see all the findings in an X-ray. And if the pain is persistent, then you can ask for MRI. You refer to a specialist and ask for an MRI. So what's the treatment in lumbar muscular strain is to make the patient comfortable and reduce the pain. You have to spend at least 10 minutes for the advice to ask them to avoid activities or movement that worsen the pain. The ice therapy during the initial 2 to 3 days during the acute period to reduce the inflammation, and then the hot fermentation for increase in blood circularity of the muscles. You can give NSAIDs and muscle relaxants and physiotherapy and gentle stretching. So we have to explain the patient, it's all you give only a temporary relief. There is a chance of so the second common one is the intervertebral disc collapse. So you suspect when there is an acute pain by lifting the leg, and there will be a burning pain or weakness by lifting a heavy weight. So suspect lumbar disc collapse. So this is the normal disc, as I told. This is the nucleus pulposus. This is the annulus fibrosus. Essentially, you have the spinal cord, and through the intervertebral foramen, the nerve root comes out. So what happens in disc prolapse is the annulus fibrosis gets weak due to either degeneration or a trauma, and the nucleus pulposus comes out. Suppose if it comes out and presses on the central part of the canal, it's called central disc prolapse. You'll have the obliteration of the normal concavity of the disc. Suppose if the nucleus pulposus comes out laterally and presses on the root, you'll have the severe radicular pain with a neurological deficit, depending on the amount of compression and the local inflammation. So these are the two main things you have to see in disc prolapse. And this is a degenerated disc. There will be narrowing of the disc space. So the radiating pain will be a dermatomal distribution. The patient will tell the numbness over the particular area. The common disc are the L4 or L5 affecting the L5 dermatome, L5S1 disc affecting the S1 dermatome. So if there is any history of bowel or bladder dysfunction, bilateral sciatica and saddle anesthesia, so it shows a severe compression of the cauda equina, which is an emergency. So there will be positive straight leg test and positive femoral stretch test may suggest upper lumbar disc herniation, which is unusual. So the causes for the disc collapse is complex. It can be a mechanical inflammatory process and the degeneration of the disc, and also the genetic influences have been found to be more important. But nowadays it's more seen in young people, even in the adolescent age, maybe probably due to inactivity or repeated injury. So associated with increasing aging, smoking, and abnormal pelvic morphology and change in the sagittal alignment. So the investigation is diagnosis only by MRI, and the management only two treatments are available, either conservative or a surgical decompression. So only if the patient has pain and over the limb and there is no neurological deficit, you can do a conservative treatment, and if not, treatment. The conservative treatment is rest to the initial days and the NSI days, as I told in the lumbosacral, the muscle strain. So the surgery is indicated if there is any persistent radicular pain and the patient is not able to tolerate, and if there is any neurological deficit. So if there is saddle anesthesia, sphincter dysfunction, as I told, if the cauda equina syndrome, which is an emergency, the emergency decompression has to be done within 48 hours. This is the only emergency in disc collapse. So only a few more minutes. So the third one is the common one, it's a compression fracture. The compression fracture usually is an anterior column fracture, and it's a stable one. It's considered to be benign injury and nothing needs to be done for this fracture. So most of the causes is a trauma, osteoporosis and malignancy. If you suspect malignancy, you go for an MRI. Otherwise, there is no need for an MRI. And the history of trauma also, most of the patients, the old age group, they do not give a proper history because they may not know the significance of the trauma, and there will be 2 or 3 vertebral compression fractures. So plain X-ray is enough. Only MRI if you suspect any malignancy or any infection. So the management is the limited bed rest, give analgesia and NSAIDs. You can do immobilization with brace during acute phase, and you have to treat osteoporosis. There is vitamin D and calcium supplements and regular exercises, which consists of balancing and the muscle strengthening exercises and the movement of all the joints. So at the primary health setup, when will you refer to a specialist? This is the most critical one because you should not miss any diagnosis. So what are the red flag signs? Generally, if the pain doesn't improve in 4 to 6 weeks of time with conservative therapy, or there will be night pain or the pain at rest, and there will be progressed motor or sensory deficit, it needs immediate referral. So suspect carcinoma, as I told, is more than 50 years, and there's any history of cancer in any other organ, unexplained weight loss, or loss of appetite. Any fever and the recent infection like UTI or immunosuppression, patient is on immunosuppression drug, you suspect infection, and that's also a red flag sign. And if there is any history of injury, and there is osteoporosis and significant trauma, and there is any chronic oral steroid use, you can refer to a specialist. Another thing is, as I told, is the cauda equina syndrome. That's an emergency. And abdominal aorta aneurysm, you suspect there is an abdominal pulsating mass and the age is more than 60 years. So the pain at rest is a danger sign in a low back pain. So what's the role of primary health care? So elicit the natural history of the back pain. So that's the most important one. And next, address the patient concerns and goals. As I told, you spend at least 10 minutes. So it's a patient-centered care. So you explain him about the pain and tell them that there is chances of recurrence and you need regular exercises to prevent it and nothing to worry. So maximize the functional status of the patient and give some relief to the pain by giving analgesics or muscle relaxants, improve the associated symptoms such as sleep or more disturbances, and promptly you have to refer if you suspect any complication, and teach him about the prevention, which will come later. So the prevention and education is the most important one, because 97% of uh, pain is due to mechanical cause, and among that maybe more than 90% will be only just a strain or a sprain. So we have to insist them on to our weight reduction and the normal postures to be followed. This is a normal posture, all should be straight, should not be flexed or in the extended positions. While driving, the spine should be straight, should not be curved, and while sitting also it should be straight, and the hip and knee should be at the same level, and both feet has to rest on the floor. These are the postures should be avoided. Always you need a back support, and it has to be straight. And the sleeping, previously you used to tell them to lie on the floor, but it's not necessary. It's a firm mattress is enough. And here also everything will be in a straight line. So accordingly you have to keep a thin pillow. So ask them to avoid lifting and carrying weights. So you always think before you lift, because once you get the disc prolapse, it's very difficult to treat and come back to normalcy. And think whether you can manage the lift. But if you want to anything to pull, you push rather than pull the weight. Avoid pulling the weight; it causes more strain on the back. And this is the ideal way to lift a weight. The main concept is the spine has to be straight all time. You should not bend like this, because there will be a curvature of the spine. So this has to be straight. You flex the knee and then slowly lift the weight. So all the time the spine has to be straight. The next most important to prevent the recurrence is the exercise. So the most of the patients, if you tell the exercise, they will do it initially, and once there is no pain, they will stop it, and again they will come after a year or two. So also tell them that the pain may recur at any time. So these are the various exercises. The aim of these exercises is to strengthen the muscles of the back and the abdomen, so that the strain doesn't go into the spinal column. So the take home message, to summarize it: so back pain mostly diagnosed clinically. There is no need for any investigation. Exclude the red flags, and refer immediately if you see any red flag. And don't forget about the concerns and expectation of the patient. Imaging is not a must. Medications is not everything. So when you suspect cauda equina, refer. So not every patient deserves a complete rest, and some are contraindicated. Thank you.